An order just came in from the emergency room. We have a patient who just took a fall. She's got a hurt knee, so we're going to go ahead and get our room set up and our materials together so that we can get the patient back to the ER in a timely manner. For our knee x-rays, we're going to be using 10 by 12 IRs. We'll be placing the IR into the bucky lengthwise. It is a left knee that we'll be shooting, so I'll be putting my left marker on the left side of the IR. When the patient has her x-rays, the radiologist will be able to see that the marker is on the lateral end and the bottom part of the x-ray. So I'm going to push my IR into the table, take my tube and detent it to the IR. So at this point my IR and my tube are in line and we're ready to bring in our patient. Ladasha?
Yeah, right here.
What is your last name?
Smith.
And your date of birth?
7/8/83.
Okay. It looks like we're taking a couple x-rays of your left knee today. Is this correct?
Yeah. Mm-hmm.
Did something happen? Did you fall or?
No, it's kind of embarrassing. I just started at a gym and I was doing kickboxing, and apparently I'm not that good at it.
Okay. Ma'am, is there any chance of pregnancy whatsoever?
Man, I sure hope not.
Okay. When was your last menstrual period?
Oh, it was like 2 weeks ago. I'm fine.
Okay, well it'll be pretty good, so come on back. So the patient is lying on her back. Her distance from the hip to the table is less than 19 centimeters. Therefore, I have a tube angulation of 5 degrees towards the feet. I'm going to turn on my light and I'm going to move the patient into position. I'm going to have the central ray entering about 1/2 an inch below the apex of the patella. I'm going to collimate my light so that it is about 1 inch on both the lateral and medial side of the knee, and make sure to get enough of the proximal tibia and fibula and distal femur in the picture as well. Looks like we're good here to shoot the x-ray. Okay, so for the AP knee, we're going to want to have a KV of about 75. And a mass of about 10 to 15. Ma'am, go ahead and hold still. Okay, you can relax. So the tube angle is still at 5 degrees cephalad due to the fact that her hips measure less than 19 centimeters away from the table. I'm going to rotate her whole lower limb immediately, about 45 degrees. Move her unaffected leg out of the field of view there. I'm going to turn on the light and reposition the patient so that the central ray enters about 1 inch below the apex of the patella. I'm going to recollimate my light. So that I only have about 1 inch on the lateral and medial sides of the knee, and continue to get the distal portion of the femur and proximal portion of the knee. Looks like we're good to shoot this x-ray. Right, so for the knee, we're going to go ahead and have a KV of about 75. And the mass is going to be between 10 and 15. I'm going to go ahead and give the patient their instructions. Ma'am, just hold still. Alright, you can relax. So So for the lateral knee, we're going to have the patient roll onto her affected side with her unaffected leg in front of her affected knee. So ma'am, if you can go ahead and roll onto your left side. Going to have her bend her knee. Going to reposition the shielding. I still have my tube angle at 5 degrees, and I will be moving her left knee to the center of the shot, with the central ray entering at the mid-knee joint. I'm going to collimate my light to make sure I get all of her, the proximal part of her tibia and fibula, as well as the, and the distal section of her femur. And we are ready to shoot our X-ray. Right, so for the knee, we're going to go ahead and have a KV of about 75. And the mass is going to be between 10 and 15. I'm going to go ahead and give the patient their instructions. Ma'am, just hold still. Alright, you can relax. So for this shot of the intercondylar fossa, we are using a PA axial projection. It is the Camp Coventry method. I have the patient's affected limb resting angled, her knee bent and resting on a stand basically. I have the angle of the tube is perpendicular to the angle of her lower limb. The central ray is entering the intercondylar fossa of her knee, and we're going to just position the patient to get a good position. So here we have the central ray entering the intercondylar fossa at the popliteal space, or just the intercondylar fossa. And I'm going to go ahead and cone down, make sure I have about an inch laterally and medially of the knee, and that I'm including the distal femur and proximal tibia and fibula. So we're going to shoot this X-ray. Alright, for the Camp Coventry method, we're going to be using a KV of about 80. And we're also going to be bumping up the mass a little bit compared to our other knees. It's going to be about 20 mass. I'm going to go ahead and give the patient their instructions. Ma'am, please hold still. Alright, you can relax. So we're going to be utilizing the Settegast method to get a tangential shot of the patella. The patient's affected knee is bent so that it is perpendicular to the table. The patella rests about perpendicular to the table and the IR as well. The tube is angled to shoot perpendicularly against the patella as well. We're going to cone down significantly on this shot since our only interest really is the patella. So the angle of the tube is about 5 degrees, and looks like we're ready to take this shot. Alright, so for our patella shot, we're going to want a KV of about 80. And we're going to want a mass of about 30 for this particular shot. I'm going to go ahead and give the patient their instructions. Ma'am, please hold still. Okay, you can relax. So we have our exposed film of our knee X-ray. I'm going to go ahead and place it into the IR, so the IR reader, so that it can read it, and we'll be able to see our image and critique it. For the knee X-rays, the first one we want to see is in the AP knee. We want to see open femoral tibial joint space. The patella is superimposed on the femur. There's no rotation of the femur as evidenced by the femoral condyles being equidistant from each other. There's no rotation in the tibia as evidenced by being able to see the intercondylar eminence and that it is even, and there is a slight imposition of the fibular head and tibial head. For the lateral knee, you want to see that the femoral epicondyles are superimposed and that there is an open space between the femoral condyle and the tibia. For the oblique knee, you want to see the proximal tibial fibular joint space open. Both tibial plateaus are seen. Open knee joint space and the patella above the tibial side of the knee. For the intercondylar fossa, most importantly, you want to see an open fossa. You want to be able to see the intercondylar eminence. The patella is not in the fossa. There's a slight overlap of the tibia and fibula. You want to be able to see the proximal tibula and fibula as well as the distal femur. For the patellofemoral joint, you want to see the patella in profile, the patellofemoral joint space open, and the surface of the femoral condyles.